What I'm going to present today is a little deeper than what deafblindness is. Because we know, I'm sure you must have heard of deafblindness, you must have read about it, but one thing that you need to remember, that almost 95% of our learning comes from what we see and hear. So if there is any impairment in our vision or hearing, any impairment, that is going to affect our understanding about the world. This is the crux which you need to remember throughout. And the biggest thing which is affected is the communication. Communication, because we communicate through either seeing or by speaking. For deafblind people, this liberty is not there. So for them, how to communicate is all through by touch. And one good fortune is that not everybody is totally deaf and totally blind. It's a spectrum. There are some who are partially deaf, partially blind. There are some who are totally deaf, partially blind. So there are many combinations. But what major problem it creates is the mobility, communication, accessing information. Somebody asked Helen Keller that what do you think, being blind or being deaf, what is worst? And she replied that blindness separates a person from objects because you don't see what is there in the room when I walk in. So blindness separates a person from objects, but deafness separates from people. So you can understand how difficult the combination can be. As ma'am said that Sense India is the only national organization, we say that we are a only national organization only for one reason. Because we are working with partner. We are working in partnership mode. We have not set up our own schools because having one school in a country like India will make no difference. We can have 100, 200 students and children there. But what happens to all those thousands? Who will reach out? So we followed a model of partnership, developed partners, build their capacities, raised funds with them, for them. We are not a funding agency. We raise funds along with our proposals with the partners. Coming to mental health. This is something which is a cross-cutting issue. Whether you are deaf-blind or where you are so-called normal or whatever, we all have mental health needs. And psychologists are very few in the country, more so in rural areas. So that gave us a target for the next project to train more mental health professionals, right? I'll come to that. And counseling support was provided by our in-house psychologists. We had 3 in-house psychologists who were providing online as well as physical counseling support. Training of mental health professionals, this is something which came out as one of the major need areas. So to create awareness to address unique challenges faced by individuals with deafblindness effectively. I'll give you an example. We took the first deafblind adult to a psychiatrist. She was completely flabbergasted. How am I going to work with this person? How am I going to communicate? What I am saying, the mother cannot, interpret. And what the young person is saying, I am not able to understand through mother. Genuine need. Yeah? Because in counseling and treatments, you need to be very precise about what the need is. Otherwise, it can go haywire. So that was a major problem. That how to prepare psychologists and psychiatrists, mental health workers to understand deafblind, how to bridge that gap. And that's where again our special educators and CBR workers came as a big support system. They became our main interpreter between these two persons. Equip professionals to deliver mental health care specifically tailored to needs of deafblind community. We have done trainings now of mental health workers that how to counsel a deafblind person. So it's not just how to counsel, but what are the characteristics of deafblindness? Why a deafblind person behaves in a certain manner What are some of the typical ways of expression of deafblind young adults and people, how to understand them. Because for us it is very easy, our expressions show everything. Whether I am liking your what you are telling me or not, it will show on my face, my body language. But for a deafblind person, how they react, and to interpret that reaction by a psychiatrist or psychologist, so we gave the characteristic of deafblind people. That was part of the training. And provide targeted training that incorporates understanding the cultural and regional context affecting mental health and care delivery to individuals and deafblind. It's a very strong thing. You will be amazed that our respondents from South were much more open in expressing their mental health needs as compared to our friends in North. Much more open. So the need for mental health support came stronger from the southern India as compared to northern India. This is a cultural difference.
Why so?
Because they are much more expressive about themselves. And in North there are too much of inhibitions, too much of stigma. That's one classical thing which came out. Then came the development of sibling network, because siblings are very important. And to foster a supportive network that offers a platform for sharing experiences and strategies among siblings. See, parents, they have their own role, but siblings connect better. And that's why we thought that siblings can be a better link in mental health. Similar age, similar kind of pressures, similar kind of temptations on them. So we thought of developing a sibling network to strengthen and support siblings in caregiving by providing access to targeted resources and training. Again, what we did with psychiatrists and psychologists, we tried the same thing with siblings. And siblings said, "Oh, no need to tell. We know our brothers and sisters. We understand them. Tell us how we can help." So that was easy part. To enhance siblings' mental and emotional well-being, enabling them to advocate effectively for their family members with deafblindness. Not to be overprotective, but at the same time to be an advocate for their needs. Now, creating awareness, we did awareness training of various stakeholders, there's community meetings of parents and caregivers, the photographs of state level training with special educators and CPR workers. Then we did regional level for people with deafblindness, parents, caregivers, special educators, CPR workers. National level we did regional level because language was a barrier. If we mix region and we do in one language, there was less intake. People wanted their own language, so we thought that regionally we will do separately and nationally we will do separate. National level for people with deafblindness, parents, caregivers and special educators and CPR workers. We did training of mental health professionals. In the beginning they came and they were all sitting like this, folding their hands, lied back on their chair. What are you going to teach us? Typical. And by the end of the first session, they were the ones, "No, tell us more." Because they could understand they have a major role to play professionally, not any otherwise, but professionally as a psychiatrist, psychologist, mental health professionals. And then development of sibling network was another big exercise, but it has really very good, so far has come out very well. Some of the learnings, the mental health needs of, as I said, varies as per different regions. Within North, there were some states which were quite open. There were some states where things were very, very hushed up from the family side. Within the given locality, some cultures or some ethnic groups had a different take on mental health. So all this came into play when we started going into the grassroots level. In-person training we did in local and regional language, had a better impact. Adaptation in mental health based activities differed as per the unique needs of children with disabilities. The three activities we remember, the clay, my world and the breathing. That was actually what you call customized as per the person. Not everybody liked clay. We all don't. We use some text. We like some textures we don't like to touch. So it was all customized as per the need. Using no or low cost material for sustainability in all our activities. Because that is something which we want to do at the grassroots level, at home. We don't want to use very expensive material because there is a tendency in most of our families of making saving. So if you give expensive material, they'll keep it in the shelf, never use it. Mental health needs of siblings and parents also affect children with and young adults with deafblindness. So equally important to look into, ask the questions to siblings and parents also. How are you doing? And you will be surprised. The next big training we are planning is for caregivers. Because they are the most, I would say, ignored lot. They are dumped into everything, every possible activity, every possible plan that special educators make goes on to their heads. But nobody asks them question, how are you doing? The next one we are planning for caregivers. And regular visits are vital because they give in-depth knowledge, visits, physical visits. Some of the challenges that we faced, adapting the intervention of the spectrum of deafblindness among children with deafblindness and young adults. The intervention spectrum, how much depth we need to go, who would require psychiatric treatment, who would require psychologist, who would require counseling, because we are not mental health experts. We are deafblind, we know about deafblindness. Our CBR worker don't know about mental health, they don't understand deafblindness. So that has been a challenge, and that's why we wanted mental health professionals to be included as deeply as possible. Language barrier among different regions of India is a big challenge, and the only possible way is to break it down to local or regional or state level. Parents resisting mental health consultations. They said, "No, our child doesn't have any problem. No, he's fine. Very classical. Then dropout of children, young adults with deafblindness during the process of intervention. For many reasons. Migration, suddenly mother, father decided that we can't give you time, or job has started, or business started, we can't bring you, all that. Frequent change of staff was a problem at our end. Because our staff also, partner level staff also changed. In any state, if there is a advertisement by Samagra Shiksha or Sarva Shiksha Abhiyan, teachers wanted, en masse, many special educators who resign and join there. They also want their growth, but that also is a challenge for the sibling network. The way forward, my last but one slide, expanding the age range of target population. So now we are 5 years onwards, we are going upwards, addressing mental health needs of other stakeholders like parents, siblings, special educators, and creating a pool of human resources who have expertise to support the mental health needs of people with deafblindness by creating a referral mechanism. We are working on a little monetary benefit also for psychiatrists and psychologists. Once the partner organization refers them, the CBR worker refers, there will be some money also which will come to the psychologist and other people who will work with us, because that is a motivation they might have. Not everybody wants to work free, of course, they should not. Work toward advocacy to make policy level changes across regions. This is something which we are working with the Government of India, with the Mental Health, Ministry of Health on mental health. And last, this is a quote from Fred Rogers: anything that's human is mentionable. And anything that is mentionable can be more manageable because we talk about it. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. And that's where our deafblind children and young adults, we want them to start talking about their feelings and to make sure that we understand, we empower them, support them to share their feelings. Thanks a lot.
Thank you, Akhil, for such a comprehensive and on time finishing the whole thing. Now we have, we can take 3 to 4 questions because Akhil really wants to interact and yeah, you're the one first. Yeah.
Am I audible?
Yeah, you are audible.
So, sir, you were mentioning a lot about how mental health professionals are not very well versed with how to deal with deafblindness, which is understandable because I myself am a clinical psychologist and I haven't had enough exposure to deafblindness myself. So, do you have any reference to any ongoing training programs that we can attend so that we can educate ourselves better?
Now, as you say, we'll plan an online program.
Yes.
Definitely, we will. We are in the process. We have made a second proposal in which we will definitely provide, build in that opportunity. Because we want to bring in for everyone across the country. We have online programs on for teachers, parents, sign language courses, all that is online. But we have not done it with mental health professional or psychologist. And we will do it. Thank you for suggestion.
Thank you, sir.
Anyone else?
This is the basic. First of all, thank you for a very, very informative and I think concrete, practical presentation. It really helped us visualize through. My question might be more sort of because I attended Ms. Sampada's presentation on the first day, so I'm trying to link my concept and understanding. So when you say you start to assess children at the age of 5, we understood from her presentation how difficult it is to link to abstract concepts of joy, happiness, sadness, what am I feeling. So how is that process at that age, 5 to 10, like the diagnosis, I'm just saying that what is the checklist of 37 questions?
We don't have a checklist at the moment.
Okay.
Because when we started doing for 7 years, in some cases we thought that we are late. There were always issues with them.
Right.
So we thought that let's lower it to 5 years and check. We haven't got a checklist now.
Okay.
And Sampada always makes my life difficult, so we are going to include her and ask her help that how to assess on that. But very, very valid question. We have not yet designed a tool for that. But the reason was when we did on the 7-year onwards, there were some children who had severe issues.
Right.
That was the main concern we had. That we should not go with the traditional understanding that only 5 year, below 5 year there will be no mental health issue. We don't want to imagine that.
Also, if I can ask a second part to this question, is the role of IQ in this entire thing. Are we talking about how does IQ play in? Because again,
I think my understanding about mental health is
there is no relation, but in the children that are being assessed, so there would be also, because I'm dealing with IDD, so how do you tackle that? And that would be parallel to how you assess mental.
I think intelligence has nothing to do with mental health. That's what we feel, but we might be wrong.
No, it's not about wrong or right. It is about the communication, about the ability to express.
It's more of functional behavior.
Yeah.
So that's the main reason.
Right.
But if there is a connect, definitely it will come out in the next phase.
It's a very, very interesting research in terms of that 984 to break that down in how the population breaks down.
Yeah,
Thank you.
Thanks for the
So
question.
we have asked 2 questions, one this and one.
Sir, I just wanted to know, it was very interesting that when you said about the parents and the siblings being involved. Like parents are seeing that child, the sibling is also being with the child, did you have any kind of a feedback saying that, oh, this was something which we never knew about the child? Or something like, coming up which they got aware after you placed them with the children? Or vice versa?
One thing I give a lot of credit to the parents and siblings, that they were switched on when the child was, or young adult started these behaviors. So they were living with them. They were the first one to identify, because they had seen them going to a school, coming back, how they used to be, how their evenings used to be, and suddenly that change they observed. So being that observant, I think they did very well. Sometimes we don't give credit to parents and siblings that these people don't care for them, but they do. They do, definitely.
Last question. Am I audible?
So while it's wonderful to know that they, I think, has been about children, I am just wondering, is there any specifically which has come up or has been integrated for adults or seniors who have possibly, they are not born like that, but then because of a pathological reason, later in the life, they have been experiencing the deafblindness, and they've of course experienced, seen, felt, talked about. But is there any form of a training for them or for their caregivers, especially for the seniors? Because I've observed in my work, I work a lot with Parkinson's, and there are a couple of people with my group and my participants who have not had, their vision has also got affected, their hearing has also got impaired. So has there been anything for them?
Excellent question, Mudrika. Due to senile degeneration, there is condition like deafblindness in some, no doubt about it. When it comes to Sense International India, over the last 28 years, we have been concentrating more on young children and young adults. We have worked not very, I would say, strategically, but we have worked with Mother Teresa's homes, with elderly people who have deafblindness, but that is not something which we have done overall. So if there is a request, we want to work, we want to reach out to all these aged homes. The problem is resources. So if there is any connect we can find, we'll be happy, our partner organizations will be happy to go and train their caregivers that how to help elderly people who have deafblindness kind of condition in them. There are many reasons for deafblindness. There are some which are congenital, but there are many which are after birth. Adventitiously, there are many reasons, many accidents, syndromes which cause deafblindness. So in that, but elderly is a typical category. We have not done any focused kind of work, but we can definitely work into that. There is a definite need, no doubt about it. And all the more because India is going to be capital of elderly, people like me, and I'm not going to tell her, but people like me, more of elderly population in India pretty soon. I think we will require that support system.
Thank you so much. And now to conclude this wonderful session, I will say that he talked about a few points. I'll just quickly talk about them. He talked about isolation and also lack of communication as a major concern as far as mental health issues are concerned. He brought an example through COVID. He talks about psychological intervention, especially with siblings, from which even parents benefit. And he also talked about creating awareness, equipping professionals, including the mental health professionals, the teachers. And what I liked about his presentation was when he talked about the sibling network. This is not a problem only with deafblind children. Regularly, this is a problem when you have two siblings at home. But those kind of things do occur. So this was a wonderful idea he talked about. And also, since we are talking about a diverse group, he talked about the actually environmental ethos, like regional and contextual, he says it should be based on that. And then he also talked about visiting homes. And his giveaway, I'm not repeating that because he's already told you what are the giveaways, so I'm not talking about, he talked awareness and advocacy, which he so underscored. But from the questions, what I gathered was that there is a need for early diagnosis and early interventions. And he talked about, so you people talked about training of mental health professionals and the awareness of parents, how early they become aware, and if they are not aware, how to make them aware is a very important aspect of all this. And finally, the adventures deafblindness. These are the things he thinks he will deal with them in the future. So thank you so much, Akhil. Thank you so much for and when I get